Hello, my name is Angelica Redmond. I'm a medical laboratory technician and I am doing my case study PowerPoint presentation over Serratia marcescens. For the patient history, we have a 20-year-old male presented to the emergency department with complaints of nausea, vomiting, fever, genital pain, and abdominal pain. Upon arrival, the patient was triaged and had blood work drawn. Labs included was a CMP, CBC, blood cultures, coags, AUA, and later on a few add-ons. Due to the patient's signs and symptoms, the doctor wanted to rule out pancreatitis, which is why the amylase and lipase was ordered, and then a procal and lactic acid because of the fever. Most labs are fairly normal. There was some slight elevations and some levels that were decreased. Everything in the CMP was fairly normal, but the patient's potassium was slightly decreased. I think the lowest it got was a 2.8. The procal was elevated, and a procal is one indicator if you have a serious bacterial infection, it will be elevated. The urinalysis did warrant a urine culture due to the amount of white blood cells and bacteria. And then a CT was also performed, and the patient was found to have a renal stone and a renal abscess that was forming. The patient was admitted for treatment, and current diagnosis was pyelonephritis. For the blood cultures, policy for this hospital states that 2 full sets need to be drawn, an anaerobic bottle and an aerobic bottle, and they need to be drawn 15 to 30 minutes apart. This patient's first bottle had growth value positive about 12 hours later on the anaerobic bottle, and 30 minutes after that, the second anaerobic bottle turned positive. Both gram stains shown gram-negative rods, and the bottles were plated on, I'm so sorry, were plated on blood, chocolate, McConkey, and CDC anaerobe plates. The first two bottom pictures down here are of the Bactec system. This is what we use to incubate our blood cultures. And then this picture over here on the right is a picture of a gram stain showing gram-negative rods. Okay, so for our positive blood cultures, they are placed onto the accelerate pheno system. The ID typically takes less than 2 hours, and the antibiotic susceptibility testing is complete in little under 7 hours. Excuse me. What I like about this analyzer is it gives quick turnaround time, so our patients can get treated quickly and efficiently. At a previous hospital I worked at, we had to wait 24 to 48 hours for the plates to grow and then take a colony, do the McFarland standard, put the cards into the solution, and then it ran on the analyzer and it resulted the next day. So it was a lengthy process, and although, as with everything, we did have a technical error on the susceptibility testing on the pheno. This one errored out and we had to run it on the microscan walkaway from an isolate. ID on both the pheno and the walkaway came back as Serratia marcescens, and the walkaway reported plenty of sensitivities. And both bottles, they all shown the same on each plate, so both blood agar plates had heavy mucoid colonies, the same with the chocolate, and the McConkey had heavy clear colonies. Okay, so now we have the urine culture workup. Urine is straight to the blood agar plates for colony count and straight to the McConkey for isolation. At 24 hours, the blood agar plate had 50,000 colony forming units of large white colonies and greater than 100,000 colony forming units of tiny gray colonies. We took one of each isolate and put them on a microscan walkaway. ID of isolate 1 came back as Serratia marcescens, no carbapenem-resistant Enterobacter ACA detected, and isolate 2 came back as Enterococcus faecalis, no vancomycin-resistant Enterococcus detected. And as you can probably guess, this patient was severely septic. I believe this started due to the renal stone. The patient also had to use an in and out catheterization for urination at home. This probably caused a severe UTI that eventually went to his bloodstream as well. This patient was treated with vancomycin and Zosyn. The patient eventually stabilized and eventually was discharged with instructions to come back if signs and symptoms worsen. So the big question is, what is Serratia marcescens? It is a gram-negative rod. It is a facultative anaerobe, meaning it can grow in either aerobic or anaerobic conditions. Serratia is an opportunistic pathogen. It causes nosocomial outbreaks, UTIs, wound infections, bacteremia. Serratia is commonly found in moist areas of your house, such as showers, bathtubs, sinks, toilets, and pet water bowls. If you notice like the little orange reddish color in your bathtub around those moist areas, that's typically probably more than likely Serratia marcescens. Symptoms include fevers, chills, respiratory distress, and shock, which these four are usually the signs of sepsis, and the frequent urination difficulty or pain with urination and white blood cells in the urine are the symptoms of UTI. Excuse me. You can get Serratia from ingesting foods contaminated with the bacteria, direct contact, any type of catheterization, or any shared utensils, clothes, and so on. So Serratia can be easily recognizable due to the red colonies down here on the left, but not all strains will have this red color. As you can see here on the right, they can also be like a clear white colony. This is because some strains will produce a pigment called prodigicin and some won't. This organism is also capsulated and very mucoid. Here we have some biochemical tests that help determine that this bacteria is in fact Serratia marcescens. It is OMPG positive, meaning it is a slow lactose fermenter. DNase positive, this determines the ability of an organism to hydrolyze DNA. Indole methylred negative, our VP will be positive. This detects the presence of acetone, and citrate positive, meaning it has the ability to utilize citrate as its carbon and energy source. And if you ever see that IMVC, that's how they abbreviate it, and then over here the negative, negative, positive, positive, that's the reactions. For the statistics, I was trying to find recent studies on morbidity versus mortality of Serratia marcescens. The most recent one I found was an article from 2015, but here are just a few other statistics I found. So 90% of cases that have a history of a recent surgery or instrumentation from the urinary tract. 30 to 50% of patients with Serratia marcescens UTIs are asymptomatic. And in 2015, overall mortality of Serratia in the bloodstream was 25 to 58%, which is high mortality, but it's a low incidence. And lastly, we have my works cited page. If you have any questions or comments, please let me know. Thank you.